informed of new information, including opportunities to join further webinars. If you do not wish for them to retain your details, please just let us know and we will remove you from the contact list. So without any further ado, I would now like to hand over to Dr. Dermot O'Shea.
Hi, Cathy. Thank you very much. You're all very welcome to our inaugural symposium today, and I'd specifically like to thank Miriam Ahern and May Olden of the Irish Gerontological Society and Cathy and Karen of the All-Ireland Institute of Hospice and Palliative Care for their support today. So much has happened over the last few months, and they really have, for all of us, been truly extraordinary times. The dedicated, committed and compassionate work you all do, the sacrifices you have all made for the people you support, help and care for in our communities, nursing homes and hospitals around the country, and indeed globally, has earned the respect and admiration of your friends, your family, your colleagues and your neighbours. And each and every one of you deserves to be very proud of what you're doing and what you are continuing to do. We here at the IGS share that pride and respect. And when on April the 21st we decided to defer the annual meeting that was due to take place in Kilkenny this year, we did so with a very heavy heart, knowing that the voice of the IGS, both as an advocate for older people, but also as a voice for those of us involved in the care, education, dissemination of good practice, science and research in ageing, is needed now more than ever. So your IGS exec got together with the help of Miriam Ahern and May Olden and have designed this IGS 2020-21 scientific programme. And the programme will now take place over the coming 12 months, taking the form of regular online educational research and networking events, including our annual Willie Birmingham lecture, hot topic updates, special interest group meetings, and so on. And the membership year runs from September 2020 through to 21. It will be open to new members and renewed membership from August. And we will be looking for your support to sustain our society over the coming challenging 12 months. So I think it's really appropriate that we would pick the experience of healthcare workers in the field of gerontology as the first of these symposia that we put together. And I'm really grateful to our speakers who Dan, our chair, will introduce to you just in a couple of minutes. Clearly, the experience of healthcare workers will be in the main universal. However, for those of us that work with older people who have been more susceptible both to increased morbidity and mortality, some of the experiences will undoubtedly be peculiar to healthcare workers in the field of gerontology. And I guess this symposium is intended to start that process of bringing further focus on healthcare professionals and those who provided care in our communities, nursing homes and hospitals over the past few challenging months. To date, nearly 30% of COVID-19 cases in Ireland are reported in healthcare workers. And this is reflective of what we're seeing around the world during this global pandemic. It's a stark statistic that highlights that what we do is not without risk. At the same time, it is important that we explore the risks and challenges we face during these COVID-19 times. I guess we'll all be learning lessons from this pandemic for the years to come. So it's really important that we share the national and international experience. And it's gratifying that there's interest in today's symposium. We've over 500 people registered from the UK, the USA, Australia, Japan, Singapore, India, Saudi Arabia, the United Arab Emirates, and of course the island of Ireland. We each have a personal responsibility for our own health and well-being. And this is absolutely shared with the organisations we work for and our professional bodies. The experiences of healthcare workers in Ireland and around the world will inform and empower us, but we must work with our organisations and our professional bodies, and we must improve how we look after ourselves, each other, and the care of our patients in the years ahead. So before I hand you over to our chair, Dan Ryan, and Dan, I'll be getting you online now, I'd like to thank Cathy and Karen of the All-Ireland Institute of Hospice and Palliative Care for their support. And I'd also like to thank Daichi Sankyo, who have generously agreed to support the IGS as our innovation partner for 2021. So I'll hand you over now to Dan, and I look forward myself to the meeting and to the questions and answers. Thank you all for joining us. Dan.
Thanks, Dermot. Okay, so I won't keep you from the excellent list of speakers we had this afternoon. The webinar, I suppose, in essence, is unfortunately somewhat of a substitute for face-to-face, but what it does provide us with is an excellent opportunity for a high-quality Q&A. And I've gone through 350 questions that you've all submitted at registration, come out with themes, and we'll put them to the panelists for the 30 minutes after the lecture, the three exceptional lectures I expect we'll be looking forward to. So without any further delay then, I'll introduce you to Mimi. Dr. Fan is a geriatrician in the Mater Hospital, St. Mary's Hospital, and community medicine for older persons in Dublin North Central. And she's going to speak of her experience while working in the COVID pandemic, and then her own personal experience with COVID.
Good afternoon, everyone. Just bear with me. There we go. Share. Share. Yeah. Yes, okay. I want to thank Professor O'Shea and the committee of IGS for your kind invitation for me to share on my experience as a COVID patient. This experience of going through an acute illness and the recovery afterwards gave me insight of what it meant to be a patient. It also allowed me to take joy in what I have and also learn patience through living at a slower pace. I will share with you the timeline of my illness, the standout moments which I was as a patient, and what helped me in the recovery. So in terms of timeline, from the end of March, I was helping out for 2 weeks in St. Mary's Hospital with a COVID outbreak. And on Good Friday, 10th of April, I had a lot of backache. And I felt that I'd done a lot of exercise. Perhaps it's linked to bending over when swabbing. I felt cold. Noted, I didn't have any shortness of breath or any cough. Just to rule out COVID, I drove to the Mater the next day for testing and then went into isolation. It was difficult to buy a thermometer at that time, but the temperature that I recorded at the clinic was 38.4. The results came through on Sunday that I was COVID positive, and then I was linked into the remote monitoring clinic. The clinic required me to submit symptoms, temperature, and also oxygen sets twice a day. The oximeter was delivered on Monday, and the phone calls came for contact tracing on Mondays and Tuesday. On Wednesday morning, I received a call from the remote clinic to submit another saturation because the initial ones was reading at 92%. Despite my effort at deep breathing to get the numbers up, it stayed around 90%. I was informed that I'll be collected by an ambulance to a COVID ward in the Mater. And on the COVID ward, I was tagged and had portable chest x-ray, and blood and IV rocafin was started then. I was also placed on nasal prongs and advised to lie prone as much as I could. By Friday, just to be safe, I was transferred to HDU for CPAP and closer monitoring. In HDU, I had MRSA, CPE, CRE swab, followed by arterial line, and then second IV line, and the next day NG, blood cultures, ECG Dopplers, ultrasound of the legs and arms, and in total 3 arterial line replacement. I had daily chest x-ray, arterial blood sampling a few times a day, and overnight NG feeding, as my appetite was affected by COVID. Just as an aside, I noticed that when the arterial line was flushed as large volume and very quickly, I experienced shooting pain and cramps in the hand. IV magnesium infusion was also painful. And when the crushed medications were put through the NG, there was an unpleasant cold tickling sensation at the back of the throat. I'd actually rather take the tablets by mouth myself. I was discharged from HDU after 10 days to the National Isolation Unit, Burnett's Ward, and was discharged on the 30th of April, 15 days in the Mater. I only packed for 3 days' clothing. My family had to bring in clothes, and the hospital services also provided complimentary laundry. For those 15 days, I saw masked faces of staff who cared for me. Their voices were muffled through the visor, the mask, and also the background noise. All the interactions were through PPE. Yet through the tone of their voices, I experienced their kindness. Going through an acute illness gave me insight and perhaps made me more empathetic towards the patient I look after. That is why COVID had been an enriching experience for me. Observing what went through as a doctor and also as a patient was thought-provoking. I want to share with you some standout moments. Minimizing illness. When I was told that the results of COVID was positive, I thought I'll be the 85% of people that stay at home. And when I was admitted, I thought I'll be the 15% that stay on the ward. And eventually I became the 5% in the critical care. I always thought that I'll get better in a few days. Perhaps minimizing helped us all cope. Embarrassment. Initially, I didn't want my illness to be made known to the others. Firstly, I wonder, how did I get COVID? I thought I was practicing hand hygiene and precaution. And then secondly, when the oxygen saturations fell and I needed evaluation in the hospital, I asked if I could drive in. The answer was an emphatic no. I thought of the embarrassment of being collected by ambulance and ambulance men in full hazmat suits, and what would the neighbors think? I wanted to keep the illness to immediate family. Only 6 people knew, except when I appeared in Irish Times, Irish Independent and Prime Time, and then the news was out. When we think of conditions such as falls, dementia, incontinence, we may not want to admit to the people close to us, which result in late presentation and increased severity. Perhaps this is how our patients feel. Unconscious habit. Oxygen therapy, I discovered, dried up the mucosa and is really noisy. I was not free to move around as I was linked to the oxygen pipe on the wall unless they gave me a 10-meter cord, which I might trip over. It was hard not to think about falls prevention when I was a patient. I also discovered there was a mouth breather and the oxygen wasn't getting in. So at one stage I was putting the nasal prongs into my mouth, which helped the oxygen, I hoped. And that wasn't very well received because they thought I was delirious. So I learned to pinch my lips with my finger so that I'll breathe through my nose. Hard to change an unconscious habit. Trusting the experts. I was told that I was a good patient and did what I was instructed. Could it be my Asian upbringing? No, I believe that it was the trust that I had developed over the last 9 years. I heard these consultants spoke so eloquently in their expert area. I'd become now their patient. I realized together with their expertise, there was compassion in abundance. They review me well after 6 p.m. and also at the weekend. I want to thank Professor Jack Lambert, Sean Gain, HGU consultants, and the Marta team. This reminds me that building trust with the older person and the family is vital. It is the warmth and the expertise that come across, especially older people with dementia. They look at our body language and our genuine care instead of the words that we speak. Wearing CPAP while lying prone was not comfortable. At night, a tight mask and pressing air into your airway. Lying prone was painful for me as well. I found it hard to find the right position so that the mask would not press against my face. It required mind over matter to endure the discomfort and to remind myself that this was the treatment which will make me better. And the expert has recommended this, and my job is to breathe and listen to them. I wonder what steps we take to encourage our patients to receive unpleasant intervention that will help them understand. One of the consultants said to me, I remember, about wearing CPAP. He says, I wear it too. Your breathing will get better. And perhaps our own experience will help us convey to our patients what it is like to be a patient. Dependency. The following comes with warning of too much information. And I feel that it is important to share because it provided insight into how our patients may feel. In the HDU, I was tethered to the bed with 1 arterial line, 2 IV lines, NG, CPAP, and ECG leads. There were bed rails as well. This meant that I needed full assistance for washing, grooming, dressing, toileting. I was vulnerable in case somebody would open the curtain or forget to turn off the surveillance camera. The nurses were professional, warm, and demonstrate long-suffering patience. I got to know them a little bit better through their 13-hour shift. I learned their names, and some of them had worked in HDU for 18 years and others 18 months. We talked about COVID. I could tell from the interactions that they were person-focused rather than task-focused. The meal times For the meal times, I was changed from CPAP into AVO to allow me to eat. AVO, if you're not familiar with it, is a high flow mask over the nose. It's like a high-grade nasal prong. And it delivers FiO2 up to 60%, delivering 15 to 45 liters of oxygen per minute. The high pressure air rushed out from my mouth every time I opened it. And it was a challenge to eat under such circumstance. So whenever, whether it was porridge or jelly or yogurt or mashed potato, they flew out of my mouth and landed in the front of my t-shirt during the meal times, I laughed because I became the messy eater. I gave up finishing the meal. I now understand when I see food stains on my patients' clothes and why they do not finish their meals. Hiding the evidence. When I was on the ward before HDU, I had an adverse reaction to the IV antibiotics and had one episode of explosive diarrhea which destroyed my pajamas and bed sheets. My immediate reaction was, I want to sort it out myself. I want to hide the evidence. I want to throw away the clothes and make sure that I make the bed myself, even though I was really short of breath. So we want to hide evidence of our dependency and incontinence. Bed rails. Fearing incontinence became a fixation. My day in the HDU was timed by the use of the commode, and anytime I see a nurse, my thought would be, do I need a commode? I was tethered to the bed with lines, and transferring out of the bed required help of one, which prevent me. I want to make sure that the lines won't get dislodged. And I was on diuretics, IV magnesium, calcium channel blocker, overnight NG feeding, which all contributed to urgency. I learned that when I press the bell, only when I was desperate, so that I don't bother the nurses. It took at least 15 minutes for help to come, from someone acknowledging the bell to donning on of the field PPE. And by the time the nurse came in, I was edging myself to the end of the bed rails, rattling it and leaping onto the commode for fear of incontinence. When we hear the bell on the ward or call for help, remember, in a minute to the patients can cause significant anxiety. We, the patient, only press the bell when we're desperate. Incontinence may not be due to environment, it may be due to environmental factors for not getting up to the toilet on time. I will look kindly when I see my patient rattle the bed rails and their frequent requests for toileting due to a fear of incontinence. Overthinking. It was about a month later that I realized that I was hypervigilant during this period. I had a lot of back pain while lying prone, particularly at night, and in fact, I dread the night time. Paracetamol wasn't effective. My thoughts were, what was the cause of the pain? Was it radiculopathy? Was it COVID related? And then the treatment, pregabalin, would it make me drowsy? And I see the side effects of it often in my patients. And what about oxynorm? It could be constipating. Then I would need Movicol, and then the effects of laxatives. These double guessing was in my head often. And I wonder if these symptoms were COVID related. I asked about skin changes, I asked about transient redness over the joint, the blocked ears, the clumsiness. Not knowing the reason for symptoms may cause anxiety. And worry over the side effects of medications make us tolerate the pain instead. And the repositioning of the pillows and the cold packs and the back rub all helped. But the fear of recurrence of pain was very real. So I made sure that when the nurses come in, that I always have the checklist of pillows, ice packs, and tablets. It helped me identify with my patients that they may have fear of recurrence of unpleasant symptoms, and perhaps they ask all these questions. Jelly legs. Getting out of bed in the ward in the St. Bernard's was wonderful, but harrowing as well. I was unsteady and really breathless. I had hoped that my sets and balance would allow me to get to the toilet from bed. I thought that I might fall. This is what 2 weeks of decreased activity felt like. I was totally deconditioned, but it wasn't acute illness, but it was actually the sarcopenia that can set in so quickly. The after effect of COVID really overwhelmed me at that time. What was that catchphrase? 10 days in hospital bed leads to 10 years worth of muscle loss. Wanting to connect. The desire to connect with others, the nurses, the doctors, the cleaning staff was strong when I was in isolation. To find commonality, to laugh together, to learn their names and also to share life experiences. I wonder if the nurses and cleaning team thought that I wouldn't stop talking. Thank you all for your text and the human interactions. It meant a great deal. perhaps talking about matters not illness related make us more human, and that we connect together. Coming home, it was lovely to feel the breeze on the face, to see the grasses moving in the wind, to watch the sleet hit the window, to taste homemade food, and also tea in a mug. That was wonderful. What I realized was that there was also a sense of quietness. There was no hiss from the nasal prongs, no call bells, no drone of the negative pressure fan. Early days in the recovery were marked with nausea and breathlessness due to desaturations. Examples such as climbing stairs or showering, I had my sats were around 83 to 85%, and there was exhaustion where I had to go to bed in the middle of the day. My family waited on me. I thought rehabilitation was to be active around the house and go for my walks, but rehabilitation was more than that. I went to St. Mary's, and they provided me ways to get better. Eilish, the senior OT, provided goal settings and strategy to pace myself, because I have a tendency to do too much. And Kate, the senior physiotherapist, gave me progressive strength and endurance exercises. The improvement came and plateaued. It is important to set goals, but also to rest. Finally, I learned that I don't need to be vigilant all the time. I can rest and not achieve the goals that I set out to do that day. Improvement takes time, but I know it will come. What helped? Perspective, I think, is key in going through situations for me. From my childhood, I've gone to church, and in my adult life, I've continued in my faith. My cousin, Reverend Tiong, sent me these verses from Isaiah. I saw it in HDU as a reminder to me that I'm not going through these episodes alone, and I'm well loved. So these verses were a reminder that I'll be taken care of and I'll be all right. And I also know that my family and my church community are praying for me. Also, I had tremendous support. My husband Sam and my daughter Callista, my brother John in Malaysia, whom I have to take all these pictures for, which you'll see later on, the church community, Martha geriatricians, and Mary and Trish were two wonderful nurses that delivered Fanta Orange to HDU. And colleagues at Martha came by and say hello. St. Mary's Hospital and community medicine and geriatrician and IGS team, they all send your texts and cards and calls and emails and flowers and hampers. I knew that I was well loved. And finally, gratitude. I'm thankful to go through the experience of COVID-19. It gives me insight into the patients that I look after. I know what it was like in small ways to be dependent and also to work towards recovery. I'm thankful that there wasn't a COVID surge so that I can have CPAP and lying prone to allow my lungs to heal, and I didn't need mechanical ventilation. I'm thankful that I can breathe better and for the time to recover and to be with my daughter. I'm thankful for the specialist team that look after me and also advised to return to work on a phased basis. I had exercise, good food, social connectivity, and creativity. I have a few pictures to show you. This was me before I became unwell, and this was me on admission to COVID ward, tagged, IV inserted, and lying prone. And this was me in HDU with a CPAP, and this was me having the AVO, which caused the food to fly out my mouth. And then I went into the National Isolation Unit. This is a picture of my oxygen pipe, but I wanted to take a picture of the bathroom because my first shower caused a flood. The oxygen pipes were floating, my slippers were floating, and I caused the Martha an extra set of PPE to clean up the flood. These are my chest x-ray when I was in hospital. I had many biomarkers of COVID, including the high dimers, ferritin, abnormal liver function test, lymphopenia, and also low albumin of 26. And this is me heading home. This was me with Professor Lambert, and this was me getting ready with my bags packed to head home. I had lovely homemade foods. I was going for walks and trying to get my step count up, and I had opportunity to do creativity. 2 weeks following my discharge, I went to the respiratory clinic for a review chest x-ray, and as you can see, there is a significant improvement, but though there was some restrictive pattern on PFT, my dimers were still abnormal at that stage. I want to thank all the people who send messages and get well wishes to me. I record them down to show me how amazing the group of support that I have. And finally, I want to pay tribute to my mentors, Dr. Morgan Crow, Dr. John Levin, Dr. Dennis Keating, Professor Joe Duggan, and Professor Sean Murphy, who were responsible for my SPR training. And post-CCST, I had Professor Roseanne Kenny, Professor Davis Coakley, J.B. Walsh, and Professor Colonel Cunningham, who instilled in me the work ethics and compassionate care for the love of geriatric medicine. Thank you. And these are the pictures that I could take when I was going for my walk. Thank you very much.
Thank you, Mimi. And thanks again for being so open about such a personal ordeal, and certainly going through the registrants' questions. So many people were interested to hear about your personal experience, and it's one that we're so fearful of and still do fear. How did you manage that the whole handing over of the reins to other healthcare workers, which is such an alien concept for all of us?
I think that the key thing is that I have the intrinsic trust. These are the people that I've seen when I was working in the MATA, and I knew they were expert. COVID wasn't an area that I knew best, so I was very happy to trust them. And if you said I was a good patient, I was a compliant patient at that time, and they were the expert, and I asked questions.
And what would you say is the key to your sustained positivity throughout this? I'm sure there was some dark times.
I think if you're a geriatrician, you are automatically optimist, because, you know, we see small improvement in, you know, if an older person can stand up, we cheer. So if we as a group are intrinsically the ones that always look for the positivity. And but also my mother is 86-year-old. She remains positive. So there is nothing to be positive about.
Very good, thanks. That's excellent, Mimi. And maybe we might come back to you again, because it's very interesting to hear your description about the rehabilitation process, and quite a lot of questions came through from allied health professionals and from nurses around post-COVID rehabilitation. So it would be excellent to hear directly from you about that experience and what you envisage might be necessary to prepare for that next stage. I might bring you now to Professor Paddy Mallon. So Professor Mallon is Professor of Microbial Diseases in University College Dublin and Infectious Diseases Consultant in St. Vincent's Hospital. And he's trained initially in Sydney, Australia, completed a PhD in HIV. He's director of the UCD Centre for Experimental Pathology, Host Research, which focuses on translational research into outcomes of infections such as HIV, COVID, and TB. His own research interests include age-related outcomes in HIV, which would be of particular relevance to this forum, and I'd be very interested to hear in what way that specific niche interest has informed his approach to COVID. So I'll hand you over to Paddy, who's going to share his slides. Thanks.
Thanks, Dan. I'd just like to add my best wishes to Mimi for a very speedy recovery, and also for fascinating insights from the patient perspective, which really are invaluable. And thanks to the Society and for Dan for the invitation to speak to you today. I'm going to give you, I guess, a bit of background in terms of our own experiences here from a gerontological perspective in terms of how we dealt with the COVID crisis, focusing a bit on healthcare workers, but also on our approach to the outbreaks within the residential care facilities locally. So as Mimi's touched on, there's a lot of aspects about this infection that really don't follow the conventional wisdom. The normal thing from an infectious diseases physician perspective is that if you have an infection, it infects a host, there's some form of interaction which causes an illness, you target a treatment like an antibiotic in the hope that you can sway the outcome more towards a positive outcome rather than a negative outcome. And with every new condition, every new disease that comes along, it's amazing just how we realize just how little we know about this whole process, and COVID's no different. For an infection that's only been around since January time, we've learned a huge amount about this, and there's a lot of aspects of COVID infection that are very unusual. as Mimi pointed out, that not everyone that ends up with the infection will actually be unfortunate enough to end up in hospital. And even those hospitalized patients, again, not everyone ends up requiring the more intensive ICU care. And at each stage, there are probably different pathways or different determinants that will dictate whether someone improves or someone disimproves. And even within that setting, what we're starting to realize in this post-COVID space is that regardless of which part of the pathway you enter that post-COVID space, that there's a lot that we don't understand about this virus, even in terms of its resolution or the impact on recovery. And a lot of this is really open to the need for a huge amount more research. And when we start to understand the types of things that are driving the disease, it's becoming apparent that the actual role of this virus is probably in the very early stages, definitely around transmission and probably in the development of early symptoms. But what's determining the worst outcome in individuals seems to be more host-driven rather than pathogen-driven. And there's certainly good evidence now coming to light to show that the sicker patients are getting sick because of a really inflated host immune response. It's very abnormal and probably very difficult to predict. Accompanying that and probably related to it are coagulation disturbances. And this is something that's really novel. I've never seen this sort of thing with a viral infection, but we're seeing people with very abnormal coagulations. We're seeing people coming in with prothrombotic events such as PEs, maybe even sudden deaths. And that's all driving end organ dysfunction. And this end organ dysfunction, the immune disturbances and the coagulation disturbances, we're starting to see the impact on that sometimes even weeks and months after the recovery from the acute illness. So therefore, the types of treatments that we're going to be targeting at each stage of this condition are really going to depend on what process that we want to interfere with in terms of trying to shift this graft more towards meaningful recovery. So this is what COVID in Ireland looked like. This is our first wave. Really what we were looking at very early on was an infection that had very high levels of community transmission that persisted for quite a long period of time before thankfully starting to settle down now. And I would hope that we'll continue with a very low or close to zero case definitely during the summer with the current measures that we have in place. Around Ireland, the distribution is an interesting distribution. You can take a lot from this, but certainly a concentration in terms of population or cases per population density that was really focused on the north and the northeast. And whether or not this is related to our open land border with a UK and a different type of control strategy, I think there would be a lot of discussion about that and a lot of research on that to come, but certainly quite an unusual geographic distribution of cases. When we look at the characteristics of this virus, I'm sure that you're all aware of this sort of 2 to 3 week gap that's dictated our lives as we've recovered from the first wave. And this 2 to 3 week gap is really reflected in how this virus acts within a population. As Mimi described, there's a certain lag time between getting exposed to the virus, developing symptoms before you actually get very unwell. And most people that are presenting to hospital very unwell are becoming very unwell about between 8 and 10 days after acquiring the illness. So what that means is roughly you have this 2 week cycle of a virus entering into a population before you'll actually start to see clinical presentations on a large scale happening at hospitals. And when you look at the gap between what we saw in terms of the starter restrictions and the emergence of residential care facility outbreaks as being a major health issue, you're probably looking at a gap of quite a short gap, but a gap of about 4 weeks. So roughly 2 cycles of the virus. And this graph probably better predicts what actually happened within the Irish community. So this is a graph where you're looking at cases, the number of new cases being reported every day. Blue is the number of community cases, red are the cases reported in healthcare workers, and green were those reported from long-term residential facilities. And you can see that there's almost an automatic sort of 1 to 2 week gap between increases in cases in the community, and you start to see them emerging in healthcare workers, and then another 2 week gap before you start to see the outbreaks within the residential care facilities taking off. And this in real time shows you how the epidemiology of this virus evolves during outbreaks. Now, these sorts of data, I think, are important because when we go to look at what caused the outbreaks in long-term care facilities, there was a lot of talk about this being driven by patients being discharged from acute hospitals, perhaps without tests in the long-term residential care facilities. But this was happening very early on. This was happening in the lead up to the St. Patrick's Day weekend, was when most of these discharges were happening. And it's a much longer gap before you start to see the increases in cases and outbreaks within the long-term residential care facilities. What's much more likely is what we see is a rise in community cases, which obviously, because of the community transmission, would involve healthcare workers, and then those healthcare workers transmitting within their own work environment, whether it be, with the majority of it obviously being unintentional, probably in the early pre-symptomatic or sometimes even asymptomatic phases. And as a result of that, you start to get outbreaks within residential care facilities or some institutions that were maybe less well prepared than others. And definitely within the acute hospital setting, it was around this time that we started seeing a lot of nosocomial transmission, and that's when we started bringing in the issues around healthcare workers wearing masks and gloves that have persisted to this day. So some insights that are there from that. The other interesting thing about the residential care facilities is that we talk about a vulnerable population, and we talk about vulnerable populations in residential care facilities, but there's some data that would suggest that individuals in residential care facilities are no more vulnerable to worse outcomes than the general population. So although we had a lot of cases in residential care facilities and we had a lot of deaths, the death rates within the crude mortality rates within those in residential care facilities almost were a mirror image of those that were seen in similar similar age groups within the community. So we have a population that was as vulnerable, probably more vulnerable to infection, but as vulnerable as a general population in terms of mortality. The big difference here was that in the general population, when you look overall here at the cases, we were able to protect quite successfully our older populations. You know, the number of infections in the older populations was much lower. It was focused in the younger people. And obviously, the ability to offer that same protection within the long-term residential care facilities was less. So the overall mortality, 17% seems higher, but the relevant mortality within specific age groups was similar. So our own personal experience, well, at St. Vincent's quite early on, colleagues like Diarmid and our other geriatrician colleagues at St. Vincent's had set up a 7-day-per-week specialist nurse home virtual support service. The geriatricians had a rapid access phone service. We'd had a frailty car working out of our emergency department for some time, funded through Sláintecare, which was operating at weekends. But quite quickly, we realized that this really wasn't going to be enough, and it was mid-April that we started to get a lot of reports from our local care facilities that they were having large numbers of cases, but not so much cases as cases and staff. So the staffing issues were a big problem. And it was getting to the point that some residential care facilities, because of staff absences due to illness, were nearing the point where they were probably unable to provide safe care. And as a result of that, and the lack of PPE, the lack of oxygen, the lack of medical advice, there was a real danger that some of these facilities were going to decant their clients into the acute hospital setting. And to give you an idea, at that stage, we were operating on probably 80 patients, inpatients with COVID, so 4 wards in the hospital with COVID. If we had a nursing home decanting another 20 or 30 patients into the emergency department, it probably would have been enough to overwhelm the emergency department and certainly overwhelm our inpatient wards. So there's a quick recognition, given the number of residential care facilities in our area, that we needed to do something to support that. And that's when a lot of colleagues stepped up to the mark. So our geriatrics colleagues, our colleagues in emergency medicine, our nursing colleagues and ID, we got together, we increased the frailty cars. So we got 3 cars brought in to give a 7-day cover. And a lot of that was manned by the emergency medicine NCHDs and our geriatrics colleagues. There was a lot of support calls to residential care facilities. We actually did 35 visits to local residential care facilities and provided a range of services such as infection prevention control advice, hands-on nursing support, as well as on-site medical assessment. And some of the IPC advice was in a way very basic, but it was just something that a lot of the care facilities that we visited found useful. So simple things like one-way flow through systems to try and avoid cross-contamination between different areas, looking at workspaces to make sure that we tried to decrease risk of transmission within workspaces, advice on masks, the sort of the mask usage that we were using in the hospitals, we advised for those within residential care facilities, even though up to that stage the HSE advice was still a few days behind, and also advice on how to use PPE. And we did get the one thing that was really remarkable for me was that there were some residential care facilities that were coping incredibly well and really had no issue with COVID. Yet geographically, within a few hundred meters, you would have another healthcare facility that was in a lot of trouble. Very stressed staff, a lot of staff illnesses, and a lot of clients who were ill. But I think these interventions did work. We managed to keep all of the residential care facilities operating. We had a very low admission rate. Obviously, any admissions that were there were entirely appropriate. It wasn't that we were encouraging the care facilities to send people in who needed admission. But a lot of people with COVID within the residential care facilities were actually either asymptomatic or had symptoms that didn't require hospital admission. So this sort of wide variation in response, the key was that many remained COVID-free. And when I looked at the care facilities that remained COVID-free, there were a few characteristics that I saw that were interesting. The first was that they were really well organized. From very early on, and when I say early on, I'm talking about probably St. Patrick's Day, when we were making our plans within the hospitals, they were making their plans within the residential care facilities. This included active daily staff monitoring. It included a staffing plan that looked at their full-time equivalents and where they were accessing their staff from. And some care facilities really veering away from any reliance on bank staffing, for example. Other care facilities actually bringing staff that were living in overcrowded accommodation on site and offering them accommodation with relevant physical distancing. They had outbreak plans in place. They had on-site availability of medical cover, and a lot of them had already identified infection prevention control threats. So they'd done assessments of safe working workplaces. They'd done assessments within the workforce to make sure that it was as safe as possible. And it also ensured that they had access to PPE. And a lot of this was really driven by leadership, and especially within the nursing cadre within the residential care facilities. Strong nursing leadership really, I thought, was very clear in those centres that were coping well with this pandemic. And I think that certainly the engagement with public health, IPC, and outreach advice, it wasn't just residential care facilities that were having trouble. We also got a lot of residential care facilities that wanted us to come out and have a look just to make sure that there was nothing that we could do to help improve what they were doing. So it really was strong leadership and strong advice. Now, obviously, there's a lot of this stuff is you could say in retrospect is common sense, but it was actually it's interesting when you read this HICWA report that was put out on 21st of April. So this is really, if you think about it, this is in the height of everything that's going on. But a lot of the recommendations in this are exactly what were happening in those facilities that were successfully managing with the outbreaks. So just in terms of where we go forward, I think that going beyond what the residential care facilities can do in terms of the preventing infections and preventing transmissions, I think that the treatment for people with COVID is evolving. There's a huge number of treatments that are being being investigated, and I think it's important that we make sure that these treatments are adequately used in patients regardless of either their resus status or regardless of where it is they're coming from. Because as I've already shown you, the mortality rates and the death rates are similar, which you would imagine the responses to treatment may also be similar. A huge number of treatments that are being explored experimentally, some of which, like remdesivir and dexamethasone, are now being touted as a standard of care. And I think it's important that we actively treat everyone and ensure that there's adequate access. Unfortunately, a lot of these treatments are now starting to fall off the list, so we don't have a huge number of effective treatments. But I think moving forward, the target in the immune system is going to be important. And for example, a drug like tocilizumab, which targets inflammation in IL-6, can be very effective at switching off this hyperinflamed response. This is the case series we've just studied, or we just published, of the first 7 patients in St. Vincent's who got tocilizumab, and pre-tocilizumab, high oxygen requirements, but very quickly within 5 to 6 days, we saw that normalizing, and all of these patients being discharged well and avoiding ICU care. And I think we need to understand the use of these drugs, particularly in the older populations, because it is targeting, specifically targeting the immune system within those that have severe disease. I think is going to be key to improving survival. And we're enrolling in clinical trials within Ireland to try and explore this. So the COVID-19 002 trial is now trying to bring forward tocilizumab and explore that within different settings to get more information. The other key area for residential care facilities, I think moving forward, is to prevent the infection. And I think there needs to be a greater focus now that we're focusing more on containing this infection in the community. There needs to be a greater focus on which treatments are best to try and prevent transmission. And certainly the antivirals, it's things like hydroxychloroquine, for example, which has antiviral activity, remdesivir, and some of the interferons, I think, are going to be useful adjuncts in this. And it may be into the future that if we see pandemics such as coronavirus or coronavirus outbreaks within residential care facilities, that we'll actually focus treatment on those that don't have the coronavirus to prevent them acquiring it, rather than trying to treat those that do. So just moving into the future, I think there is going to be a likely resurgence of infections over the next couple of months. And now that we have over the first wave, it's now that really it is the time to try and protect against future outbreaks within the residential care homes. The limited proven therapies do work and the mortality remains high. So this is a persistent threat. And I think the consistent ICT training is going to be essential. Active monitoring, ongoing surveillance, access to testing for clients within residential care facilities, but testing with a short turnaround time. All of these things are going to be key to try and maintain safety within these institutions. And I think there really needs to be a critical look at what has been shown to work and make sure that we take the lessons of what works and bring those forward. And I think what we've shown is when we're all in a way all in this together, we're all reliant on each other. And I think that there really needs to be an encouragement of an integrated approach between acute hospitals and residential care facilities so that we can work together to ensure the best treatments are provided right across the board and try and learn from each other to ensure that the pandemic doesn't reach the outbreak levels that we've seen in the last few months. And obviously further research into therapies and prevention, but focusing specifically on those that are most vulnerable. And these treatments may need to be medicinal because there would always be concerns that a vaccine may become available, but may be less effective in those that are older with decreased immune responses generally to vaccines. So I think we need to think of other options. So I'll finish there. I just want to acknowledge all my colleagues in the elderly care, ED, and infectious diseases at St. Vincent's. It's been great working with them over the last few months in terms of the plan, and look forward to working with them over the coming weeks and months to try and prevent this from happening again. Thanks a lot.
Thanks, Paddy, and thanks for an excellent presentation and with so many different elements of covered within the same talk. Just one question. In Tallaght, we've observed maybe that the nursing home outbreaks can reflect the community clusters. Is that what you've observed, or is that your experience at a national level?
I think that looking at the data, I think the community clusters probably fed into healthcare worker clusters, which probably fed into clusters within patients within residential care facilities, and that sort of 2-week cycle within the epidemiology fits better with that. I don't think that these cases were brought in from the community into the residential care facilities by patients or their families, because there's just too long a gap. A lot of the residential care facilities had closed the visitors for, much before the schools closed, for example, and it was just too long a lag. So the epidemiology currently really supports that this was probably unwittingly brought in by staff, unfortunately.
Yeah. I suppose I more mean that maybe some of the media narrative is around the idea that this could have been absolutely prevented, whereas in reality, some of the clustering, while preventative measures are extremely important, some of the clustering occurred in some of the more epicenter regions of this pandemic.
I guess the one critique that you could make is that, but from January, when we saw this disease evolving in China, it was very clear that this was a condition that in which severe cases, hospitalizations, and mortality were much higher in the elderly. The second thing that we learned from the outbreak in Italy, which was in February, was that healthcare systems were overwhelmed if you didn't protect your elderly populations. And the third thing, again, from Italy that predated what happened here was how devastating this could be within the nursing home setting. So everything that happened here was entirely predictable. And the question needs to be asked, what was all of that information that was available quite early in the year? How was that digested and how was it translated into adequate protection of a vulnerable population? And I think that that's a question that would really, that I would hope would be addressed within the current reflection that's going on at the moment. It's being led by Cecily Kelleher.
Very good. Thank you. And that's definitely something maybe we could put out to the panel at the Q&A time, if that suits. I just asked one quick question also. Your observation that the lag in nursing home peak delay was 2 weeks later than the community, could that have been because of the atypical presentation of nursing home patients and maybe the initial lack of access of nursing homes to testing?
Yeah, I think they're two really good questions. That the atypical presentation was really key, and I think that we had what we called a COVID pathway set up here within the hospital, that we streamed anyone that we thought may have been a suspicious COVID away from the main hospital population. And if we hadn't done that, there would have been, at least in the initial stages, a number of people coming in from nursing homes with acute on chronic delirium, for example, that would not have fitted the classic COVID picture, wouldn't even have probably have been fitted within the HSE guidance on who should be swabbed. And so that was a really important lesson for us. And I think moving forward, those atypical presentations, because they weren't described too much from previous outbreaks. So I think there's a big lesson. The testing piece is, again, controversial, because this happened within an environment where we were not getting effective turnaround times for tests outside of acute hospitals. And I think moving forward, that we really need to look at that, and we need to look at that within residential care facilities in general, because if you're not getting fast turnaround on an outbreak, you don't have a good handle on the outbreak. And with COVID, if you're waiting 3 to 4 days on a test result on someone who has a temperature and they come back COVID positive, you probably lost the initiative already. And that, I think that really is well demonstrated as to what happened within the nursing home sector. And that goes back then to moving forward. If you can't access that fast turnaround time, we really need to find a system where we can integrate ourselves, because if the nursing homes are left vulnerable to an outbreak, there is a knock-on effect in terms of the acute hospital system, and we need to recognize that we need to work together to protect the system from start to finish, and that will include a good reaction time to tests.
Very good. Okay, thanks. So maybe we'll put that to the panel then after the next speaker. And so the next speaker then is Denise Hartigan, and thanks for speaking today, Denise. She's a CNM2 for stroke and older persons in Connolly Hospital and was in the midst of this. So maybe Denise, you might be able to give us we're looking forward to your talk on your experiences. You're on mute, Denise.
Thanks, Dan. My name is Denise. I'm a CNM2 here in Connolly Hospital. First of all, I would like to thank the IGS and Dr. Diarmuid O'Shea for inviting me to speak here today. I'm going to talk a little about how COVID-19 changed communication on the ward in which I work. A little bit of background and introduction. Pre-COVID, I was CNM2 of a 28-bedded stroke unit, care of the older adult ward, which included 8 acute stroke beds. We had an established MDT, including our physiotherapists, occupational therapists, speech and language therapists, dietitian, medical social worker, discharge coordinators, clinical nurse specialists, and of course our doctors. Our teams were based on our ward. We had set MDT meetings weekly and had established a pathway for care planning meetings twice a week. We built strong relationships and good communication with both patients and families. We didn't have access to a step-down rehab facility on site, so many of our patients were with us for a prolonged period, many for many months. The nursing team was also very established, with many of our senior nurses working on the ward for many years. In hindsight, we had our normal. On the 19th of March, 2020, everything changed. Our ward closed. We decanted patients to other wards, to nursing homes, and some returned home. At that time, I did not know when or what we would be opening as. We opened 5 days later as the largest COVID positive ward in the hospital. It happened quickly, with everything changing rapidly in those early days, not even daily, but hourly. This resulted in the nursing staff levels being immediately reduced, as many of the staff were going sick, with some being immunocompromised and unable or unwilling to work in the environment. We had staff nurses redeployed to our ward on a daily basis, with some of these staff nurses not having worked on an acute ward for many years, coming from areas such as outpatients and endoscopy. There was a palpable fear amongst them, and indeed amongst us as well. This was not something any of us had ever experienced before. We had different teams of doctors rotating every 3 days. Our own MDT team was dispersed throughout the hospital, with many of our physios going to the ICUs. The physios providing therapy on our ward to the acutely ill were also rotated. In those first 2 to 3 weeks, the patients we treated were younger and often very sick. As nurses, our skills were tested as we adapted to recognizing the early signs that our patients were deteriorating. Patients who initially presented quite well and could then become acutely unwell, often several days into their admission. This virus attacked in various degrees. Monitoring O2 sats, titrating oxygen, proning conscious patients, all became our new normal. Anesthetics became our best friends. The use of PPE, the time it took to don, the time it took to doff, training staff to use PPE properly, effectively, and confidently, all took time. Setting up donning and doffing stations outside each ward area, We did adapt and we found a rhythm, and then our cohort of patients changed. And overnight, we became a COVID positive ward for the over 65s. A significant number of our patients were arriving from nursing homes with a number of comorbidities, along with their COVID-19 diagnosis. Many had a cognitive impairment, hearing impairment, which we as caregivers were now impaired in our communication because of the need for PPE. The fundamentals of care we provided were made so difficult, and often I felt it was dehumanizing to our patients. We looked like aliens with our masks, our goggles, our hazmat suits, our gloves, and I wondered often, how did our patients feel? As a profession, nurses are tactile. Touch, smile, the holding of a hand, we're all now compromised. We all look the same, dressed in the PPE, which often made communicating with each other difficult. We spent less time with our patients. We became task-driven, every interaction requiring higher levels of organization and structure, taking vital signs, dispensing medications, and feeding patients. This in itself was really unpleasant. Food was served on paper plates, on cardboard trays, plastic cutlery, plastic glasses, all grey and disposable. Often food remained untouched, with this becoming an ongoing concern for me throughout. Our communication with families was extraordinarily difficult. We had a significant amount of deaths. 33% of all deaths in Connolly Hospital happened in our ward. The high level of phone calls from families to the ward was unprecedented. Each family member requiring time, reassurance, medical updates, which often resulted in them receiving upsetting and sometimes devastating news. I felt the weight of the ward on my shoulders going home many days. We provided video calls with families, which were facilitated by our social worker, Emer, our nurses, and our healthcare assistants. These calls were often the only interaction between a patient and the family. For some, it provided reassurance and addressed the sense of isolation. But sadly for others, it was the last contact we had, or they had, with their loved one before succumbing to the virus. Many, many calls stand out in my mind, and I'm speaking for all the nurses, all the healthcare assistants and our social worker when I say we were often left bereft after these calls. One video call in particular to a mother who sat alone at her kitchen table and spoke to her son for the last time. She was so incredibly strong for him, but it was apparent to us that she was devastated. He died an hour later after that call. She didn't see him after. She was also not able to have any of her family able to visit. He was an only son. This is the reality of COVID-19. We would have on the ward before COVID valued really highly the end of life journey of our patients. But I think one of the hardest parts of the 10 weeks we were a COVID positive ward was not being able to support patients and their families in the way that we would have been used to. Following on from this, we came together as a group in the hospital and we developed an idea for a bereavement box, which includes mementos, a handwritten card with messages from the staff who cared for the patients who died. Currently, we are inviting in family members and allowing them to talk to us about their loss and for us to talk to them about the final days of their loved ones. And then they receive the little token. We've only begun these sessions, but it does seem to offer some sense of comfort and solace to the families of the bereaved. Visiting is still severely restricted, And although we have returned to being a stroke unit and care of the older adult ward, everything is different and challenging. Wearing masks are a constant. Care meetings are done on a tablet. Social distancing is part of our reality. In conclusion, COVID-19 changed everything on our ward. We had always prided ourselves on being well-trained, well-positioned to deal with any difficulties or emergencies arising. But this represented a new, unprecedented level of communication with our patients and each other. We became counsellors to our patients, to the families, and to each other. Patients and families needed this. And in the aftermath of COVID-19, it is absolutely apparent that staff need this as well. Thanks a million.
Thanks so much, Denise. That's a wonderful presentation, and I'm sure it was a very, very difficult time, particularly, as you say, for frontline staff, for healthcare attendants, for nurses, and also for the medics involved. In your own experience, quite a lot of, so of the 350 or so registrants, quite a lot of people alluding to exactly what you've described: the burnout, the psychological stress, the fear. How did you maintain morale during that time? That's what one of the most pervasive questions I witnessed was.
Yeah, I suppose in the early days, we were just living, you know, day by day. And I think, you know, I was talking about this before this presentation. I relied heavily, and I think my colleagues nursing and through all the MDT, we relied on each other. I know myself going home, I didn't feel I could talk or burden my family with it. So I spent a lot of time when I went home on the phone to my colleagues. I think there will be a lot of learning from this. I know that there are staff care hubs. We have opened a quiet space in the hospital that, you know, staff can go and reflect. But I do know that it was really survival mode in the beginning. And often when I look back, it was, you know, talking to one another and reliving. We did, yeah, there was we have looked at bringing in debriefing, but I do think if you are going to bring in debriefing, it needs to be from a totally independent, you know, body, because I don't think debriefing works if it's, you know, within your own organization. So it's something that I would love to see being rolled out.
Okay, and if and when potentially a second wave ensues, in what way would you approach that, approach kind of the morale component to this, the burnout element? In what way would you structure the service?
I think if we do have a second surge, I think I would look at rotating staff. I think, you know, having spent 10 weeks in this COVID-19, being the largest COVID-19 ward in the hospital, I look at nurses now and indeed various other members of staff, and they all talk, even still, they talk about being unsettled. So we're talking about, you know, as if the first surge is finished, and I don't think any of us really realize the impact that it's had. I would definitely look at rotating staff. I think, again, I think we would need to look at debriefing on a regular basis. Yeah, I think that's something we would definitely have to look at.
Very good. Okay, thank you, Denise. That's wonderful to hear your insight into it. I suppose moving on to maybe some of the more general Q&A that have been submitted. Paddy, is geriatrician Louth and Director of Nursing in Galway asking about whether or not you might or might not know of the breakdown of those healthcare workers affected by COVID or contracted COVID in terms of their speciality.
No, I think that piece of work is still ongoing. I know that the data coming from nationally is suggesting that probably about a third or close to a third of the national cases were in healthcare workers, and I think the vast burden of that was probably by the nursing profession, the direct frontline carers. In terms of the proportions that were within the hospitals versus community. I haven't heard that, and I think it's something that they really need to drill down in.
Yeah. Okay. Yeah. No. I suppose there is this complex analysis of data potentially, whereby, for example, the Newcastle data from a single site showing 15% of COVID-facing healthcare workers had COVID in the height of the pandemic, while 16% of the non-clinical healthcare workers had COVID. Do you think that more reflects an access to testing and a selection bias, or do you think there is also maybe cross-contamination within the system as well?
I guess the one of the things about the testing bias that Ireland's a bit different from a lot of other jurisdictions is that we did have a short period of time where we did have open testing within the community. Now, there was in for a lot of criticism because there was a big backlog, but the majority of those tests were actually completed. And when you look back at those tests, so we do have a period of a denominator, and therefore it is real that healthcare workers as a workforce were overly represented in terms of the overall community burden of COVID-19. It's not, it isn't we tested more healthcare workers, because in the period that we were testing everyone, healthcare workers were showing up clearly as a signal. And that is something that I'd said to government, that everyone needs to look at that critically, because it shows you what impact this has on the workforce. Because I know that from the same point, when we were at the height of that healthcare worker outbreak, we were down roughly 25%, and it was expected that we would be down 25%. And again, predictable, but it shows you what effect this condition has within a healthy workforce if you let it go rampant. And we're only now starting to understand what impact that's having long term. There's still, when we have our post-COVID clinic, the vast majority of people attending the clinic are working in the healthcare sector, because they're the people that had the most disease burden. So I think there's a lot of, there really needs to be a very critical look at this in terms of why people ended up with the infection. One of the things that I was most proud of in terms of working within a COVID unit was the fact that if we had really well trained staff, dedicated staff, and we had very few episodes of COVID-19 within frontline staff that were actually carrying COVID. And I think the lesson that I learned from that is that if you want to protect your health force, you've got to ensure that you protect your health force through training them, but also through offering them sufficient levels of protection, PPE at the right time. And I don't think that we really grappled with that well enough in the early stages. And I think that a lot of the healthcare worker transmissions within the hospital could have been avoided, and definitely be accepting that level of transmission going in. That just shouldn't be happening. Okay, thanks. I might put it to Deirdre and Denise, because if you take Toronto and the Ontario group, Ontario as a state, 25,000 positive cases, so quite similar to ourselves, but 4,000 healthcare workers testing positive as opposed to 8,000, and their positivity versus testing rates are very similar to ours. So you anticipate that there's probably not a discrepancy or a selection bias from that perspective. What would the panel feel then, Deirdre, Denise, or Dermot, around the underlying reasons that a high volume of healthcare workers in this country tested positive, perhaps higher than in other countries?
There is something in relationship to the infection prevention control, and I know that the HSE and JP Nolan's team are looking to have infection prevention control nurse specialists in each CHO to support people to understand the process of infection prevention control in breaking the cycle. So I think that we've been lacking in that expertise out in the community, which is something that's being addressed now.
So the poll is up there just for everybody, and we get the results immediately. So you just click and it'll disappear off the screen. Sorry. Okay. Thanks, Deirdre. Yeah. So you're trying to address it at a national level. Denise, what's your thoughts on the attrition rate that you've observed on the ward, and potential measures that may or may not have prevented it?
I don't know, but I certainly think that testing in the initial stages and throughout was problematic. I know here it got much better and results came back much faster, and it improved as we went on. I do think, you know, our infection prevention and control here were very fast off the mark. Like everywhere else, we had problems with PPE initially. Certainly we had various types of hazmat suits and other things coming in. That would have been in the initial stages. I think it did improve. So hopefully going forward that we would be much better prepared if we did have a second wave.
I think the other thing, Dan, you know, and obviously Paddy's talked about testing, training and education being critically important in preparedness. There's huge lessons to be learned from other sectors. So if you look at the success in the Irish Prison Service, where they were very sort of active in both education and training and staff specifically. So I'm not saying, clearly the people in the prisons were able to adhere to social distancing measures that were obviously easier, but that was all an education piece. So I think we've got to be prepared to learn lessons from other areas and how we can improve. And I would sincerely hope that and I'd be really interested when you get the poll in, how many people are going to say that they'll take the flu vaccine this year, because for me, there are lots of different things we can do. There won't be a vaccine for this, but you'd like to think, and Paddy might comment on this, you'd like to think that the learn we've all got in the last 3 months from hand washing, you know, hygiene, social distancing, that's got to have implications for more than just coronavirus, you'd like to think. But equally, we're all waiting anxiously for a coronavirus vaccine that isn't going to be here anytime soon, but the flu vaccine is there. So Paddy, I don't know if you have any comments to make on that.
Yeah, I mean, there's two things. With any pandemic, the key is that you have to have a plan. And if you don't have a plan, you're always going to end up on the wrong end of it. The prison service is a really good example of that. And I'm glad you raised it. The reason that the prison service did so well is that prison services had a plan. They had a plan around TB transmission because they'd had outbreaks of TB within the prison service. And they were able to adapt. They were doing a lot of IPC training within the prison staff around TB. And that was mandatory for all the prison staff. They adapted that when COVID came along. So in a way, they were able to adapt an IPC plan that was widespread, education that was widespread to a different disease. And you can see the impact on it. You know, I think there wasn't a single case within a prisoner, even though they had the same problem that hospitals are having. They had people coming to work with COVID, but because they were all attuned to it, they had the active surveillance in place. They had a pre-plan in place. They were able to put it in action. Unfortunately, some of the nursing homes that I went to, it was obvious that there was no plan. And I think that, you know, planning ahead, whether it be through flu vaccination, whether it be through ensuring appropriate education, whether it be through PPE, anything at all is better than nothing, and that really needs.
Paddy, I think on that, and I take the point, but I think that's why, you know, hindsight's very easy. And somebody asked me some time ago, you know, what would if I could turn back time, what would I do different in nursing homes? And really, the answer to that is, you know, we now need to plan for the future. Yes, there will be lessons to be learned out of the. The pandemic and what happened in nursing homes, but we've got to get the plan in place and get it right now. So the report from the nursing home expert group, it's actually interesting. I'm going to interrupt myself now. It's fascinating. Do you plan to get the flu vaccine this year? 87% of people saying yes to that question. And the uptake in healthcare workers in the country last year was in the region, I think, of 30–40%. So that's a big increase. So I'm back to you because you've loaded.
Yeah. No, absolutely. Yeah. And I suppose what I would add to that is I think, you know, from a clinical governance perspective, and I know, Dermot, you were presenting into the nursing expert panel, is that a more cohesive alignment between CHO, general practice and geriatricians going forward with defined roles for each will be key going, I think, in my experience of certainly observing Sean Kennelly's management of the 14 outbreaks here in Tallaght Hospital. And also what he observed was those nursing homes that incurred outbreak early also had a longer sustained period before they managed to get out of outbreak. And Sean and Des and Ruth Martin and Alan Martin have published a paper that's on the Med archive showing 2,100 nursing home residents, which is the largest data set in the world currently from COVID, where 25% of 1,000 staff actually got COVID. So 25% of the nursing home staff in the 21 outbreaks that they have data on, 25% of the staff got COVID. And in the 21 outbreak nursing homes, they have data on about 35% of the patients got COVID, of the residents. But more importantly, and it's coming back to that 2-week lag, 1/4 of all the nursing home residents were asymptomatic, and 1/4 of all the nursing home staff were asymptomatic. So it is coming back to Paddy's point about infection prevention control, rapid access to testing, but the testing is flawed, where the sensitivity of a swab is probably 75%, and the symptom detection is clearly 60 to 70%.
But Dan, but the point, I think the issues around all of that, it's about being able to adapt and change. So one of the things that, you know, really, when I look at what happened in our own catchment area, you know, to see our ID colleagues, Paddy here included, going out to the nursing homes and going out with ED, our geriatricians, our advanced nurse practitioners, you know, it's that adaptability and collaboration that was so important. So you can have all the right clinical governance, but Denise referred to that in her talk, you know, in terms of, you know, ultimately you've got to work the problem yourself. You know, we were all dealing with new things. Things were changing at a rapid pace, you know. So I think what really impressed me, and this goes to everybody who's listening in here, what really impressed me was how people just, you know, literally battled down the hatches and really got down to work. And you got into this run of time where you know, days and weeks became irrelevant. You had no idea what they were. It was incessantly busy, and it was busy. You know, Denise described how busy it was and how harrowing it was on a COVID ward. It was equally busy and difficult on wards that weren't COVID wards, because people couldn't come in to visit, people couldn't, you know, so there was all sorts of challenges going on, you know.
Yeah, no, I agree, and the danger is with these analyses that you start to become excessively critical or negative, but I entirely agree. I think it's a given.
There was one question popped up down there, and maybe this is for a combination of Mimi and for Paddy. Vitamin D and the immunology side, and whether it should be something, given that it may not be as expensive as some of the other drugs, Paddy, you were mentioning. Do you think there's a role for that?
Can I answer that first? Because I think Paddy is the expert, so I'm just going to give you some of my personal experience. So one of the things I really want to bring across, maybe as an aside, that as a society, we are now focusing very much on nursing home care. When I walked from the acute ward onto a nursing home, I realized that the population that we have are significantly frail. They are on a significant number of medications, and they are very dependent. And while some of the staff in the nursing home are stable, this is a sector with high turnover of staff. And if you want to improve their, you know, the intrinsic knowledge that they have, we really hope that the staff will be encouraged to stay on. I remember, Deirdre, you put in a Twitter to say that if you have ICU nurses, if you theatre nurses, why can't we have nurse specialists looking after long-term care patients? So one of the things that we did as part of the learning is that when we were looking at medications that were useful or not useful for the patients in nursing home during the lockdown, to prevent frequent visits of people going into administrating medications, we took off statins, we took off diuretics, but everybody had vitamin D. So I don't know whether that helped to reduce the infection. So thank you.
Paddy, vitamin D?
Vitamin D, so I guess my background is in HIV, long-term outcomes, HIV and aging. Vitamin D has been a big component of the research in that field for a number of reasons, mainly because it's a long-term immunodeficiency. The problem with vitamin D is that it is the potential for confounding Now, vitamin D levels, when you look at it in the general population, vast majority of people will have a low vitamin D level, because the vitamin D levels are set at physiological, not at normal ranges within a population. So most people are vitamin D insufficient, and a smaller proportion of vitamin D deficient. You'll see more vitamin D deficiency associated with lower socioeconomic status. So it's a reflection of a poverty, and a lot of studies have linked vitamin D to a lot of negative health outcomes, but what they don't do is they don't correct for the poverty element of it. And when you actually do studies, we did a large study in HIV where we took people from inner city North Dublin who were HIV positive and HIV negative, looked at the vitamin D levels. They were low right across the board, because what we were looking at was a group of people that were from a low socioeconomic background, and there was no impact on HIV, no impact on any of the immunological indices or anything like that that we look at. So the key is, if you give someone vitamin D supplementation, I have no problem with it because it's safe and everyone should have a physiologically high level of vitamin D. It's not going to improve their poverty. And if poverty is the driver of the outcome, giving vitamin D is not going to change that. So it's not that I wouldn't give vitamin D, because it's a good idea for everyone to have sufficient vitamin D levels, but you just need to make sure that your expectations about the vitamin D supplementation are realistic. We do, just last week, we put through about 1,200 blood samples from the cohort that we've been collecting here over the last number of years, including 500 with COVID. So we have COVID antibodies on a large proportion of people that have come into hospital with and without COVID, and we're also doing vitamin D levels on them. And that'll give us a proper balance in terms of what, if any, role vitamin D has in terms of not only presentations with COVID, but also in terms of disease severity. I'm not expecting to see a huge amount, but that doesn't mean that I don't think that replacement or maintaining adequate vitamin D levels, it shouldn't be done. I think it should be done. Everyone should have good vitamin D levels. It just makes sense.
Dan, have you any closing comments? Dan, have you any closing comments?
No, I suppose it might just put to the panel about, because there has been quite a lot of questions submitted around rehabilitation, and Mimi, you touched on rehabilitation in your description of returning St. Mary's, and you know, certainly in my experience in Piedmont Hospital, we're observing a lot of post-COVID fatigue, low exercise tolerance, sarcopenia, nutritional issues, swallow issues. Mimi, what's your thoughts on it?
So certainly, you know, even if I've worked in stroke rehab, when it comes to your personal rehabilitation, I think it requires the expertise of the multidisciplinary team to speak to me in terms of not trying to do too much, that you get fatigued. It's time to rest. It's time to pace yourself. I think the physio, Kate, told me that my shoulders were up into my ears. Why am I so tense? I think, you know, it takes somebody else to call out that, you know, you're not rehabilitating properly. And I would say that for the population, there's so many in the population that had COVID and fatigue. I think it's really building up your exercise tolerance, doing the exercise, even whether I want to do it or not. I need to go out for my walks. I need to do the set of exercise. I need to make sure that I eat properly. And these are all so there's something actually positive that I need to know, that I need to do. So I think the HSCP's expertise needs to come to the fore at this stage for a large group of population. That would be my personal addition to the discussion.
Deirdre or Denise?
Well, of course, this is my favourite subject because it's the frailty, the whole aspect of frailty, and I really think that Tilda are going to show us a huge amount of what's been happening post-COVID with our population over 50, and we can translate that then into education. One of the things that really stood out to me over COVID was people's lack of understanding of frailty, and in particular the signs and symptoms of how people were presenting. And so we were looking for coughs and sore throats, and temperatures with the population that never present like that. And we were then aghast that there was people falling and starting to have incontinence issues and starting to become delirious. And even the WHO didn't put that in their signs and symptoms for a long time. So I do think we're going to have an awful lot of issues to deal with frailty and post-frailty recovery, and that understanding frailty as a long-term condition and the multidisciplinary team and the tilde research that would be translated into practice as we go forward is crucial to getting our population back on its feet. And I've just put there into the chat, we need to get up, dressed and moving, whatever that means to you. And as Mimi has said, it might have meant walking 300 steps one day, but it's about building that up.
Very good. Okay. Dermot, over to you if you'd like.
Yep. So listen, I think I just sincerely like to thank, first of all, Dan for how he's handled this and shared it, got us up and running. Miriam and May, our three speakers, I think each of them gave a real expert eyewitness account of what has been going on. And we have had so many questions and things in that one of the things I wanted to say at the end was, if you have any suggestions for how we should take these things forward over the next year, please feel free to get onto us through the IGS website and through Miriam. So a sincere thanks to everybody. The CPD certs, for those of you who want them, will be coming out to you automatically. We've had a huge number of people online at the meeting today, so it'll take time, so bear with us with that. And recording of this will be available later on in the next week, the next little while. I don't know exactly when, which will be available for those who couldn't make it. But a sincere thank you from everybody here to Paddy, to Mimi, and to Denise for their contribution. So I might hand over to Kathy to close out, or just to close off. We've just run over time. We were keen to keep it going. I'm delighted that we've had our inaugural seminar, and you will be hearing more from us in the coming months. Thank you all very much. Kathy, we'll let you close out.
Of the comments that are coming in through the chat, just thanking everybody and appreciating the fantastic presentation. So thank you everybody, and hopefully we'll see you on some seminars again in the future. Take care. Bye bye.
Bye. Thank you. Thanks, Paddy.
Thank you. Bye bye.
Denise, thanks a million. Thanks, Mimi. Much appreciated.